Hello everybody. Today we are going to discuss about ACC guidelines which are published in 2025 for the management of patient with acute coronary syndrome. So first we will see the pathophysiology. So the pathophysiology of acute coronary syndrome is based on forming a rupture of the atherosclerotic plaque. Now what leads to the formation of atherosclerotic plaque is the lipid accumulation. Now, whenever there is progressive lipid accumulation and inflammation in this atherosclerotic plaque, then that leads to the rupture, which leads to the release of these lipid particles into circulation, and that leads and that causes the activation of the coagulation pathway, which leads to the thrombosis formation. Whenever this thrombosis formation occurs into the epicardial artery, then that leads to the myocardial ischemia and eventual necrosis, and that is called as myocardial infarction. Now, broadly, this acute coronary syndrome is divided into NSTEMI and STEMI. NSTEMI is manifested when there is a partial occlusive thrombus, and STEMI is manifested when there is a complete occlusive thrombus. Now we will see what are the ECG features of this STEMI and NSTEMI. NSTEMI in ECG, it is manifested as new or presumed ST segment elevation of more than or equal to 1 mm into more than or equal to 2 anatomically contiguous leads in all leads other than V2 and V3. For V2 and V3, criteria is slightly different. It's more than or equal to 2 mm in men of more than 40 years. And if age is less than 40 years, then the ST elevation criteria is more than or equal to 2.5 mm. And in female, regardless of age, it's more than 1.5 mm. For the posterior leads, that is V7 to V9, should be obtained in patient with suspected left circumflex occlusion, particularly in the setting when we are seeing there is ST depression of more than or equal to 0.5 in lead V1 to V3. So guys, for NSTEMI, criteria is new or presumed new or usually dynamic horizontal or downsloping ST segment depression of more than or equal to 0.5 mm in more than or equal to 2 contiguous leads, or T-wave inversion of more than 1 mm in more than or equal to 2 contiguous leads with prominent R wave with R by S ratio of more than 1 and transient ST segment elevation. Many patients with NSTEMI have either non-specific ST segment and T-wave changes or normal ECG. So the absence of electrographic evidence of ischemia does not exclude ACS. Now about the types of myocardial infarction according to the universal definition of MI. So type 1 is caused because of the atherosclerotic plaque disruption. Type 2 is caused because of the imbalance between oxygen supply, myocardial oxygen supply and demand. Type 3 when it is manifested as sudden cardiac death. Type 4 is related to PCI and type 4 is post CABG. Type 4A4 is again divided into 4A, 4B and 4C. 4A is post-PCI-MI caused because of the procedural complication and it is detected in less than 48 hours. Type 4B is caused because of the coronary stent and the stent thrombosis. Type 4C is caused because of the coronary stent restenosis. Now, type 5 is post-CABG related and it is detected in less than 48 hours or after CABG surgery. So, initial in-hospital assessment, whenever we are suspecting the patient with ACS, ECG should be obtained within 10 minutes. So, if suppose there are no specific changes in ECG and our clinical suspicion of MI is high, then we can take the repeat ECG or we can send biomarkers in the form of cardiac troponin and high sensitivity troponin. If it is normal, then we can repeat in for Then we can repeat the biomarkers after 1 to 2 hours. For high sensitivity biomarkers, we should repeat after 3 to 6 hours. Now for the management of patient if presenting with cardiac arrest. If any patient presents with the cardiac arrest and after achieving ROSC, ECG showed STEMI, and if the patient is in normal GCS, or even if the patient has or even if the patient is comatose, it is recommended to immediately shift patient for urgent PCI to improve the survival. If the patient uh, uh, so in patient in patient who had suffered from cardiac arrest, and now from history, if we are suspecting there is a strong history of acute coronary syndrome, but ECG is not suggestive of ST segment elevation, then we should not rush to shift that patient to shift in PCI, because it early because even if it's because this early PCI or late PCI won't cause any mortality difference. Now let's talk about the standard medical therapies which we are using for acute coronary syndrome. Now the oxygen target is 90%. So if we should correct the oxygen only when the SpO2 is below 90%. Now, for pain management, we are this guideline suggested 4 drugs, that is nitroglycerin. Nitroglycerin, guideline suggested actually 3 drugs, that is nitroglycerin, morphine, and fentanyl. So, nitroglycerin we can administer by sublingual route as well as by IV route. If you are planning to administer nitroglycerin by sublingual route, then the dose is 0.3 to 0.4 mg every 5 minutes as needed up to total 3 doses. So please note, before administering nitroglycerin, we should always check for the blood pressure. If the blood pressure is more than, it is necessary to keep the systolic blood pressure of more than 90 mmHg to admin if you are planning to administer nitroglycerin. If you are planning to administer nitroglycerin by IV route, then the dose is 10 microgram per minute. So, and we should be before administering nitroglycerin, we should know that we are not dealing with any right ventricular infarction. The other drug that we can administer is morphine and fentanyl. If you are planning to administer morphine, then please note the dose is 2 to 4 mg that we need to administer for every 5 to 15 minutes. Maximum dose is 10 mg. And for Fenta, the dose is 25 to 50 microgram. The maximum dose is 100 microgram. So we should before administering morphine and Fenta, we should keep in mind that it may delay the oral effect of P2Y12 therapy. Now about antiplatelet therapy, we can administer the drugs like aspirin, clopidogrel, prasugrel, and ticagrel. The dose of the aspirin is 162 to 325 mg loading, and for maintenance, we can administer the dose of 75 to 100 mg. For clopidogrel, loading dose is 300 to 600 mg. The maintenance dose is 75 mg. For prasugrel, the loading dose is 60 mg. Maintenance dose is 10 mg if weight is more than 60 kg and age is less than 75. And if the age is more than 75, then we need to be very careful. We need to reduce the dose of prasugrel to 5 mg. So the dose of ticagrelol loading dose is 180 mg and the maintenance dose is 90 mg. So whenever we are suspecting the case of ACS, it is advised to administer at least loading dose of aspirin as soon as possible to reduce the death and the major adverse cardiac event. Now the other class of antiplatelet, that is P2Y12 inhibitor. So oral P2Y12 inhibitor should be administered in addition to aspirin to reduce the cardiac event. If there is history of stroke and transient ischemic attack, prasugrel should not be administered because of the worst clinical outcome. So if we are planning to take the patient of NSTEMI for immediate PCI, then it is recommended to administer prasugrel and ticagrelor. Please note the clopidogrel we should only administer clopidogrel when we are not planning to administer prasugrel and ticagrelor, or if it is contraindicated. For STEMI patient who are for STEMI patient to whom we are planning to shift for PCI, the recommendations are same. We should load that patient. We should give that patient prasugrel or ticagrelor. Clopidogrel is generally not recommended, and it should be only administered when we have already thrombolized the patient. Then, and if we can't use prasugrel, ticagrelor, then. So please remember, there are only two indications for administering clopidogrel in STEMI patient. When, when we have number one indication, when we have already thrombolized the patient of STEMI, and when we cannot use prasugrel, ticagrelor, then the next option is clopidogrel. So in patient of the NSTEMI who are planned for invasive strategy, and if you are not planning to take that patient for PCI for within 24 hours, then we can treat this patient with clopidogrel and ticagrelor. So in this diagram, it's they have summarized which antiplatelet we should use if patient is diagnosed with STEMI and NSTEMI, and if we are planning to take the patient for PCI, then we should administer aspirin plus ticagrelor or prasugrel. It has class 1 recommendation. Clopidogrel we should administer only when we cannot use ticagrelor and prasugrel. If we are planning to take the patient for CABG, then also we should load that patient with aspirin, ticagrelor or clopidogrel. We can continue aspirin till the day of CABG and and after CABG, whenever it's safe, we can start the P2Y12 inhibitor. If we are not planning any invasive evaluation, then also the choice of antiplatelet is aspirin and clopidogrel. If we have thrombolized the patient of STEMI, then only we should administer aspirin plus clopidogrel. So when to stop this antiplatelet if we are planning for elective or urgent CABG? So clopidogrel we need to stop at least for 5 days before surgery. If the patient is on prasugrel, we should stop the prasugrel at least for 7 days before surgery. And if if the patient is on ticagrelor, then also at least for 5 days, ticagrelor should be on hold. If it is urgent CABG, then we should stop the P2Y12 inhibitor at least for 24 hours. Now the role of intravenous P2Y12 inhibitor. So there is a intravenous P2Y12 inhibitor that we can use in the form of IV cangrelor. So suppose if we have patient with ACS and we need to shift that patient for PCI, and now only we have learned that patient did not receive any P2Y12 inhibitor, then in this situation we can start that patient on intravenous cangrelor. Now, what is the role of intravenous glycoprotein 2B3 inhibitor? So there is no role of glycoprotein 2B3 inhibitor before PCI, but yes, we can administer glycoprotein 2B3 inhibitor if we have found if during PCI we have found there is a large thrombus burden, there is no leaf flow or slow flow, then we can start the patient with intravenous glycoprotein 2B3 inhibitor to improve procedural success and reduce infarct sites. Now, if the patient with or else there is a pit or this otherwise this glycoprotein 2B3 inhibitor should not be administered routinely because of lack of ischemic benefit, and they have increased risk of bleeding. Now about anticoagulation. For anticoagulation, we can use unfractionated weight heparin, bivalirudin, then enoxaparin and fondaparin. So if you're planning to use unfractionated weight heparin, then the loading dose is 60 units per kg, that max is 4000, and the infusion is 12 units per kg per hour, that is 1000 international unit per hour. So for bivalirudin, for PCI, the bolus is 0.75 mg per kg bolus and the infusion is 1.75 mg per kg per hour. For enoxaparin, the dose is 1 mg per kg subcut every 12 hourly. If the creatinine clearance is less than 30, then we need to reduce the dose up to 1 mg per kg per day. Or if the patient has received thrombolysis and if the patient is less than 75 years old, then 30 mg IV bolus dose we can administer, which is followed by 50 minutes by 1 mg per kg subcut every 12 hours. And if the age is more than 75 years, then the no bolus dose is required. And but we can administer subcut dose in the form of 0.75 mg per kg every 12 hours. Fondaparinux, the dose is 2.5 mg subcut daily with fibrinolytics 2.5 mg IV and then 2.5 mg subcutaneous daily. If it is contraindicated, if the creatinine clearance is less than 30 ml per minute. So anticoagulant therapy in patient undergoing coronary revascularization. In patient with ACS undergoing coronary revascularization in same setting, parenteral anticoagulation should be continued until revascularization. Now, anticoagulant therapy to support PCI. In patient with ACS undergoing PCI, unfractionated weight heparin can be used to reduce the ischemic event. In addition to the unfractionated weight heparin, the alternatives are bivalirudin and enoxaparin. So if you are planning to take the patient for PCI, then please do not start the patient with fondaparinux because it has the risk of catheter thrombosis. Now, if the patient is diagnosed with STEMI, then which all anticoagulant agent should be used? So, if in patient with the STEMI treated with fibrinolytic therapy, parenteral anticoagulation should be continued for the duration of hospital stay. So, patient with STEMI treated with fibrinolytic therapy who are not intended to undergo any invasive approach, then we can start with low molecular weight heparin, that is enoxaparin. Again, if we have treated already, if the patient is diagnosed with STEMI and we have already thrombolized the patient, but we are not taking that patient for any intervention, then please start that patient with fondaparinux. So if I want to summarize this anticoagulant therapy, then there are 4 agents that can be used as an anticoagulation, that is unfractionated weight heparin, bivalirudin, enoxaparin, and fondaparinux. So we can start the patient with unfractionated weight heparin, bivalirudin, and enoxaparin. They are alternatives. But if fondaparinux, if we should not use if we are planning to take the patient for PCI. The only indication for using fondaparinux is if we have already thrombolized the STEMI patient and we are not taking that patient for any PCI. Now about lipid management. For lipid management, we have used the statin. The statin therapy is divided into high intensity statin, moderate intensity statin, and low intensity statin. For high intensity statin, there are 2 drugs, atorvastatin and rosuvastatin. The maximum dose of atorvastatin is 80 mg, rosuvastatin is 40 mg. So moderate intensity statin, there is only a difference in the doses. Atorvastatin is 10 to 20 mg, rosuvastatin 5 to 10 mg. Low intensity statin, we have drugs like simvastatin, pravastatin, lovastatin, and fluvastatin, and the dose varies from 10 to 40. So we also have some non-statin drugs to reduce the LDL level. These are ezetimibe, evolocumab, alirocumab, inclisiran, and bempedoic acid. Now for lipid management, if the patient diagnosed with ACS, we should use high intensity statin. If the patient is already on the maximum dose of the statin, and if on that maximum dose, if the LDL levels are more than 70, then we should add non-statin lipid lowering agent. If the patient is who are statin intolerant, then we should treat with the non-statin lipid lowering therapy. If the patient is already on the maximum dose of statin therapy, and now if we have checked his LDL level and if it is between 55 to 69, then we should go for the non-statin lipid lower therapy, because target of LDL is less than 55. In patient with ACS, the concurrent initiation of ezetimibe in combination with maximally tolerated statin may be considered to reduce the risk of MACE. So if I want to summarize, then if the patient is diagnosed with ACS and if the patient is not on any statin, then we should start him with the high dose statin, or we may start him with the non-statin agent like ezetimibe. So we should reassess the patient's lipid level after 4 to 8 weeks. If the LDL is not less than 55, then we need to escalate our therapy. That is, if the patient is already on the high statin, we may need to add the non-statin therapy. If the patient is already on the maximum dose of statin and if the LDL is less than 55, then no need to do anything. If the LDL levels are between 55 to 69, then it's a gray zone. We need to reassess the patient's lipid profile after 4 to 8 weeks, or we can start on the non-statin therapy. If the LDL levels are more than 70, then we need to add the non-statin lipid therapy to achieve the target level of the LDL. If the patient is statin intolerant, or if it is, then we need to start him on the non-statin therapy like ezetimibe. Now the role of beta blocker. So we can start the patient, if the patient is diagnosed with ACS, we need to start that patient on the beta blocker within 48 hours, because if we use beta blocker, then it will reduce the risk of reinfarction as well as ventricular arrhythmias. Now the role of AC inhibitor and ARB. In high risk patient with ACS, like ejection fraction less than 40%, patient is diabetic, hypertensive, and anterior STEMI, then we need to start this patient on the AC and ARBs. Also, there is a role of mineralocorticoid receptor antagonists. So for starting ARBs and AC inhibitor and mineralocorticoid receptor antagonists, there are only few indications, like ejection fraction less than 40%. Patient should be at high risk, that is hypertension, diabetes, or STEMI with anterval MI. So regarding STEMI management, if our patient presents, if the patient presented to us within 12 hours, then it is always recommended to go for the PCI. And if we are already working in tertiary care center where PCI facility is available, then PCI should be completed within 90 minutes. If we are working in primary center where we cannot, where we have to transfer the patient to tertiary care center, then it should be done within 120 minutes. If we are if our patient diagnosed with ACS, along with that there is also presence of cardiogenic shock and hemodynamic instability, then it is always advisable to treat first culprit vessel either by PCI or CABG. Now, if the patient presenting to us within 12 to 24 hours, then also PCI is indicated. That means the PCI we can do, PCI is beneficial if the patient presents to us within 24 hours. After 24 hours, we should go for PCI only when when the patient is hemodynamically unstable or there is life-threatening arrhythmias. Otherwise, after 24 hours, there is no mortality benefit of PCI. And if we are planning to thrombolize the patient, then it should be done within 12 hours. After 12 hours, the efficacy of thrombolysis is reduced. If suppose if you are working in primary healthcare center and if you have encountered patient with STEMI, and if you know you cannot transfer this patient within 120 minutes, then please thrombolize the patient and then refer that patient for angiography. So do not, but please do not thrombolize the patient with ST segment depression until and unless you know that there is a ST segment depression in from V2 to V3 and there is a high suspicion of posterior wall embolism. So, since we are talking about thrombolysis, there are fibrin-specific fibrinolytic agents which are available for STEMI, like tenecteplase, retiplase, and altiplase. The dose of the tenecteplase is weight-based, so maximum dose that we can give is 50 mg. Retiplase, the dose is 10 units that we can administer, that we need to give in the dose of two doses that we need to administer in the interval of 30 minutes. That means 10 units if you are giving now, you have to wait for 30 minutes and then next dose after that. For altiplase, total dose is 100 mg. So 15 mg is bolus, then 50 mg you have to give for 1 hour and then 35 mg within this 60 minutes, within 30 minutes. So there are some absolute and the relative contraindication for fibrinolytic therapy. Absolute contraindication are any prior ICH, known structural this known this known structural cerebral vascular lesion, then known malignant intracranial neoplasm. If there is a ischemic stroke within 3 months, except for the acute ischemic stroke, then any suspected aortic dissection, active bleeding, bleeding diathesis, significant closed head and facial trauma within 3 months, intracranial intraspinal surgery within 2 months, and severe uncontrolled hypertension. And the relative contraindications are history of chronic, severe, poorly controlled hypertension, significant hypertension on presentation, that is, if the blood pressure is more than 180, diastolic blood pressure is more than 110, history of prior ischemic stroke for more than 3 months, dementia, known intracranial pathology, traumatic or prolonged CPR, major surgery within past 3 weeks, recent internal bleeding, non-compressible vascular puncture, pregnancy, active peptic ulcer, and oral anticoagulant therapy. So about the choice and timing of management strategy in NSTE. Now, if there are unstable and high-risk patient, that is, cardiac patient presents to us with the hemodynamic instability, then cardiogenic shock, then we need to take that patient for immediate invasive strategy. So remember, guys, if the patient is present with the NSTEMI, then we really need to categorize this patient into these four categories. So these and what are these four categories? That is very high risk, intermediate risk, and low risk. So if the patient is presenting to us with very high risk, that is, if the patient is presenting to us with hemodynamic instability, cardiogenic shock, then it is advisable that within 2 hours we should take this patient for immediate invasive strategy. If this patient is falling into the category of high risk, that means ECG showing dynamic ST segment changes, if the troponin levels are rising, if the gray score is more than 140, then it is advisable to take this patient for PCI at least for within 24 hours. If our patient is falling into the category of intermediate risk in STEMI, that means stable and downgoing troponin levels, ongoing ischemic symptoms, then this patient should be taken for PCI at least within 72 hours. If there are low risk in STEMI, that means patient is absolutely stable. There are no dynamic ST segment changes. If there is a low TIMI score, low GRACE score, then routine invasive or selective invasive approach is appropriate. Or we can go for other tests like TMT, coronary angiography before proceeding for PCI. So again, this diagram is pictorial representation of the management of NSTEMI. So if you are dealing with high and the intermediate risk NSTEMI, then immediately take this patient for routine invasive strategy. At least if patient is highly unstable, shock, then within 2 hours or at least within 24 hours, we should take. So we can take this patient either for PCI or CABG. If the patient is falling into category of the low risk NSTEMI, then go for the selective invasive approach. So before going for that, we can go for the non-invasive risk stratification in the form of coronary CT angiography and stress testing. If that is positive, go for routine invasive. If it is negative, then go for medical therapy alone. Now, there are some relative contraindication for routine invasive approach, that is high risk for bleeding on DAPT, severe thrombocytopenia, advanced kidney disease, acute renal failure, limited life expectancy, advanced dementia, known coronary anatomy that precludes PCI or CABG surgery, and patient's preference. About NSTEMI, as I already mentioned, if patient with NSTEMI who are at immediate and high risk, then go for immediate revascularization. Patient with NSTEMI who are falling in the low risk, go either for routine invasive or selective invasive approach. Now about the timing of coronary angiography, also like patient with NSTEMI who have refractory angina, hemodynamic, electrical instability, immediate invasive strategy, it should be done within 24 hours. Who are not at high risk and are intended for invasive strategy, it is reasonable to perform angiography at least before hospital discharge. About vascular approach, should we go for radial approach or femoral approach? So radial approach is preferred since it has reduced bleeding and vascular complication and death. So there is no role of manual aspiration thrombectomy, but yes, we can take help of intravascular ultrasound and optical coherence tomography for procedural guidance. Now about the management of multi-vessel CAD. So if you are dealing with the hemodynamically stable patient, if you have diagnosed that patient as STEMI, in angiography we have learned it has multi-vessel disease. Then we should go for successful PCI of infarct-related artery. PCI of significantly stenosed non-infarct-related artery is recommended to reduce the risk of death, MI, and improve angina-related quality of life. That means if our patient is hemodynamically stable, then we can go for the complete revascularization. That means culprit vessel as well as non-stenosed, non-infarct-related artery if it is multi-vessel disease. Now, if the patient, inappropriate patient with STEMI and complex MVD, successful PC of infarct-related artery and elective CABG for significantly stenosed non-infarct-related arteries involving left anterior descending artery and left main disease is reasonable. That means if you have diagnosed one patient with STEMI and in angiography we have learned that it has multivessel disease which has also involved left main, then we should do immediate PC of infarct-related artery, and for that left main and LAD we should go for CABG. I hope it's clear, right? So if our patient is hemodynamically stable and if we have diagnosed with STEMI with multivessel disease, then we need to go for PCA of complete revascularization in the same set. But if our patient with STEMI, if you have diagnosed patient with STEMI and it has multivessel disease which has involved left main and LAD, then we should immediately then we should go for PCA of culprit vessel, and later on we can plan the CABG of left main and the left main or left anterior vessel, whatever. If our patient is hemodynamically stable with STEMI, low complexity MVD, then multivessel PCA of significantly stenosed non-infarctated artery should be done in same setting instead of stage approach. That means initial guidelines, it was recommended that we should do the culprit vessel first and then we can go for the stage plasty within 45 days. But now the recommendation are, if the patient is stable, then we can operate on the, then we should go for the complete revascularization approach in the same setting instead of the stage approach. But in case of the scenario like STEMI, which is complicated by the cardiogenic shock, we should deal with the culprit vessel first and then the non-infarctated artery we can operate later. Now about STEMI. In the STEMI ACS with the multivessel disease, the mode of revascularization should be based on disease complexity and patient comorbidities. So STEMI with multivessel disease, if there is no involvement of left main and if you are not planning to take the patient for CABG, then PCA of significant non-culprit vessel at the time of index procedure or at stage procedure is recommended. That means if the patient is diagnosed with STEMI and in CABG we have learned that he has multivessel disease but without involvement of left main, then we can plan that then we can operate on the then we can go for the PCA of the culprit vessel and as well as the non-culprit vessel in the same setting, in that means in the index procedure, or we can plan the PCA of the non-culprit vessel as a within 45 days. That means we can go either for the stage approach. So in patient with the end-stage in whom multivessel PCI is being considered, physiological assessment of non-culprit stenosis may be considered to guide revascularization decision. If end-stage is complicated by cardiogenic shock, then also the routine PCI of non-culprit artery is not recommended. So if the patient diagnosed with NSTEMI and multivessel disease, so these are certain indication if where we should go for CABG. Like if there is significant left main coronary artery stenosis, like if there is multivessel coronary artery disease with complex and diffuse arteries, if the patient is diabetic with multivessel disease with involvement of left anterior, left left with involvement of left anterior descending artery. Then if there is multivessel CAD and complete left main CAD with severe left ventricular dysfunction. So these are the four indications where we should always go for the CABG. Now about the cardiogenic shock. In patient with ACS and cardiogenic shock, hemodynamic instability, we should always go for the we should always treat on the culprit vessel first, either by PCI or CABG. In patient with ACS with the which are complicated by cardiogenic shock, routine PCI of non-infarctated artery at the time of PCI should not be performed because of high risk of death and the renal failure. Now about the mechanical circulatory devices with patient with ACS and cardiogenic shock. Sometimes we are encountering with the situation that is we are dealing with the patient of cardiogenic shock and somehow that shock is refractory. That means that shock is not responding to our any intervention, whatever inotropic support we are starting. Then what should we do for in this situation? Should we go for IABP? Should we explore the option of VA ECMO? So according to these guidelines, there are no these guidelines are not going in the favor of either IBP or VA ECMO. Rather, they are suggesting to use microaxial intravascular fluid pump to reduce the death. What are these mechanical complications? So normally we are encountered with the papillary muscle rupture, ventricular septal rupture, content rupture, and free wall rupture. So if we are dealing with this type of patient, we should, the mechanical circulatory support, they are bridging device, but they are not definitive therapy. Definitive therapy is surgery. Now, if you are talking about electrical complication and prevention, then it is advisable to it is advisable to go for implantable cardioverter defibrillator if patient's ejection fraction is less than 40%, at least 40 days post MI or at least 90 days post revascularization to reduce the death. ICD implantation is reasonable in patient with clinically relevant ventricular arrhythmias for more than 48 hours or within 48 days post MI to improve survival. Usefulness of temporary wearable cardioverter defibrillator is uncertain in patient with ejection fraction of less than 35% to improve survival. If you are dealing with patient with acute myocardial infarction with evidence of second degree Mobitz type 2, AV block, high degree AV block, alternating Brundle branch and third degree block, then it is always advisable to go for permanent pacing. Thank you guys.